Good morning, everyone. The title of my paper is Role of Magnetic Resonance Imaging in Differentiating Acute Traumatic from Chronic Degenerative Rotator Cuff Tears. Introduction. Rotator cuff tears are a common cause of shoulder pain and can impair quality of life. Majority of them are a result of chronic degenerative causes and only a small proportion of them are due to acute traumatic causes. It is important to differentiate between acute and chronic tears as most surgeons recommend different approaches to management. So the aim of the study is to assess role of magnetic resonance imaging in differentiating acute traumatic from chronic degenerative rotator cuff tears using specific imaging criteria. The objectives of my study are include to compare acromial morphology in traumatic and degenerative supraspinatus tendon tears, to compare coracohumeral distance in traumatic and degenerative subscapularis tendon tears, and to assess signal intensity alterations in injured muscles, tendons, and bones in acute traumatic and chronic degenerative rotator cuff tears and compare them. This is an analytical cross-sectional study including 99 patients with rotator cuff tears on MRI. Initially, based on the history, they are categorized into two groups. That is, one group having a history of trauma and the other having no history of trauma. All the MRI studies are reviewed and analyzed. Morphology of the injured tendons and muscles, various parameters of acromial morphology are assessed in both the groups and documented. All these parameters are compared between the two groups. The measurements that I have included in this study are as follows. First, we'll see the measures of acromial morphology. The first one is acromiohumeral distance. Here, as we can see, it is distance between the subchondral lamina of humeral head to dense cortical bone at inferior aspect of the acromion. Acromion index. Acromion index is a ratio of glenoacromial distance to glenohumeral distance. Here, three lines are drawn. The first line, the glenoid line, joins the most lateral points of superior and inferior glenoid. The acromial line passes along most lateral aspect of the inferior acromion, and the humeral line passes along most lateral aspect of lateral shaft of the humerus. Critical shoulder angle. Critical shoulder angle is also formed by two lines. The first line connects the most lateral points of superior and inferior glenoid, and the second one connects lateralmost aspect of inferior glenoid and lateralmost aspect of the inferior acromion. Lateral acromial angle. In lateral acromial angle, the first line is the same, the glenoid line, and the other one is drawn along parallel to the undersurface of the acromion. Coracohumeral distance. Coracohumeral distance is distance between coracoid process and the humeral head, and this is measured in axial plane. The results of my study are as follows. This is the distribution according to history of trauma. History of trauma is presented for 54% of the participants, whereas there is no history of trauma in 46% of the participants. Here, as we can see, 95 out of 99 participants had supraspinatus tears, 45 had subscapularis tendon tears, and 18 had infraspinatus tendon tears. So my first objective was comparison of acromial morphology in traumatic and degenerative supraspinatus tendon tears using various parameters. First parameter we'll see is acromiohumeral distance. As we can see, acromiohumeral distance is significantly more in traumatic tears than degenerative supraspinatus tears with a p-value of 0.03. The next parameter is lateral acromial angle. Here, as we can see in this blocks plot, the lateral acromial angle was also significantly less in degenerative tears as compared to traumatic tears, and the p-value was also significant. The acromial index and critical shoulder angle were comparable between the two groups. However, it was not statistically significant. My second objective was to compare coracohumeral distance between traumatic and degenerative subscapularis tendon tears. As we can see clearly in this box plot, the coracohumeral distance in degenerative tears is significantly less than the traumatic tears, and the difference was found to be statistically significant with a p-value of 0.004. The third objective was to assess signal intensity alterations in injured muscles, tendons, and bones in traumatic and degenerative rotator cuff tears and compare them. So, as we can see in this bar diagram, Bone bruise and peaking of tendons was significantly more in traumatic tears than degenerative tears, and this was also found to be statistically significant. Stage 2 and 3 of tendon retraction are more in traumatic tears as compared to degenerative tears, and the p-value was found to be 0.03, which was statistically significant. Joint effusion was comparable between the two groups, and it was not statistically significant. Grade 2 and grade 3 fatty muscle atrophy was significantly more in degenerative tendon tears as compared to traumatic tendon tears, and this difference was found to be statistically significant with a p-value of 0.001. So the conclusion of my study is that MRI helps in differentiating acute traumatic from chronic degenerative rotator cuff tears. Parameters like bone bruise, skinning of tendons, and higher degree of tendon retraction were more common in traumatic tendon tears, whereas fatty muscle atrophy was more common in degenerative tendon tears. Studies with degenerative supraspinatus tears have lower acromiohumeral distance and lateral acromial angle as compared to traumatic supraspinatus tendon tears, whereas degenerative subscapularis tendon tears have lower coracohumeral distance as compared to traumatic subscapularis tendon tears. Discussion. This study analyzed 99 patients with MRI confirmed rotator cuff tears to differentiate acute traumatic from chronic degenerative tears, and our findings are aligning with several previous studies reinforcing the role of MRI in accurate classification. So as we have already seen, bone bruise and tendon kinking are significantly more in traumatic tears as compared to degenerative tears. These findings are consistent with Lowe et al., who has reported that bone marrow edema and kinking of tendons was more common in traumatic tendon tears. Fatty muscle atrophy was higher grades of fatty muscle atrophy was more common in degenerative tendon tears than traumatic tendon tears, which was supported by Lowe et al., who have found that muscular atrophy was present in 60% of the degenerative tears versus 29.2% of traumatic tears. Acromiohumeral distance and lateral acromial angle were lower in degenerative tendon tears as compared to traumatic tendon tears, and this was also supported by a study by Sope et al., who has found that patients with acromiohumeral distance less than or equal to 7 mm had a high incidence of full thickness supraspinatus tears. Coracohumeral distance was less in degenerative tendon tears as compared to traumatic tendon tears, and these findings were also aligning with a study by Balke et al. In our study, there were no significant differences between the two groups regarding critical shoulder angle. However, in a study by Amini et al., the critical shoulder angle was significantly less in traumatic tears as compared to degenerative tears. These are my references. Thank you.